Today we will talk about the Bell's palsy. Bell's palsy is the a term that is related to the seventh nerve, that is our facial nerve, right? So sometimes we say that it is due to viruses when the latent herpes virus activates and there is swelling in the nerve, and that actually is compressed within the bony canal of the facial nerve. But sometimes we say that the cause is actually not known, right? So we will talk about the clinical perspective in this, and here we go. So the age is basically 15 to 45 years, right? 15 to 45 years, and gender is, no specific predisposition can occur in males and equally to females, so this is nothing. Okay, but now the important point is it is onset is acute. Onset is acute, or we can say abrupt. So basically the question that can be asked is that when is the maximum weakness of the nerve from the time of onset. So maximum weakness occurs in 48 hours. So this is very, very important, maximum weakness. So how the patient presents to you, the patient says that my face is numb, and sometimes he gives the history of exposure to cold. So that means the majority of the patients will come to you in winters, right? Here just see the branches of the facial nerve. We have the branch that goes to the lacrimal gland, right? Then we have the branch that goes to the middle ear, that is the stapedial nerve. Then we have the branch that is the chorda tympani, that goes to the tongue. And obviously we have the motor branches that goes to the temporal, zygomatic, buccal, mandibular, cervical part, right? So basically it only depends upon which branch is affected. So lacrimal gland affected, no tears, no tears, right? Okay, if taste if the branch of taste, that is chorda tympani, is affected, so there is no taste. Now, if middle ear branch, that is stapedial nerve, is affected, there is hyperacusis. Hyperacusis. Right. So, if these terminal branches are affected, then there will be motor disturbances of the face. There is drooping of the face, right? We say drooping. Now, if the branch to submandibular or sublingual is affected, then there will be lack of salivation. Salivation will be hampered, right? Okay. So, obviously, other branches to the ear are also supplied by the facial nerve. Very, very less amount of area is supplied by the facial nerve. If that is hampered, there may be pain or something like that, and that's it. So there will be numbness of the face. There will be okay, cold exposure, right? Okay, then there will be abrupt onset of hyperacusis, then less of lacrimation, less of salivation, altered taste, oral fullness, oral fullness, and retroauricular pain. Retroauricular pain is due to posterior auricular nerve. Now, this is not so common in pregnant women. Bell's palsy is not so common in pregnant women, but yes, if it occurs, it's very, very worse than a normal individual. Now we come to the difference between the upper motor facial palsy and the lower motor facial palsy. So this one is the upper motor facial and this one is the lower motor. Upper motor mostly occurs in stroke and lower motor is mostly known as the Bell's palsy. That is the facial nerve lesion. The nerve part is actually affected. Now, see, the lower motor, both upper and lower part of the face will be involved, right? But in upper motor, only the lower part of the face will be involved. As there is no involvement of the eye, so there will be no Bell's phenomena here. We will talk about the Bell's phenomena here, that is seen in the eye, right? Now, there is no effect on the taste of the patient and no effect on the ear, that is hyperacusis. So three things that you should know whenever you are ruling out a patient with upper motor neuron lesion of the seventh nerve. You have to see that whether he is having Bell's phenomena or not, that is, he is able to close his eye properly or not, right? Then we have to test his taste, and then any complaint of hyperacusis. So these three problems will not be there in upper motor neuron lesion, but there can be association of hemiplegia in case of upper motor neuron lesion. Whereas in lower motor, there will be involvement of the taste, hyperacusis, Bell's phenomena, whole of the half part of the face, but there will be no hemiplegia or kind of any association like that until and unless there is any pontine lesion, right? So we have to take care that whenever we are talking about the upper motor neuron lesion, the basic lesion is actually above the facial nucleus. Facial nucleus is a place from where the facial nerve is starting, right? So it should be above the facial nucleus, that is along the internal capsules, something there, some kind of problem is there only. Okay, and the second thing that you should know, that there is no wasting or atrophy of the muscle. We know that upper motor neuron lesion, there is less of the wasting and less of the atrophy of the muscle, whereas in lower motor, in any case, right, lower motor neuron lesion, there will be more of atrophy and muscle wasting. So how I'm gonna check the facial nerve? So first of all, there is a patient, right? There is a patient. Now, see, here is the affected area. So the muscles of facial expressions will not be active here. Okay, so there will be drooping of the mouth. So there will be drooping of the mouth on the affected side, right? Then there will be dribbling of the saliva from the affected side, right? From the angle of the mouth, right? There will be frowning on the normal side due to frontalis is intact, but there will be no frowning of the affected side. No frowning. Eye closure will not be there properly. So normally what happens is when we close our eyes, the eyeball actually moves up. So we are not able to see this phenomena because our eyes gets closed, right? When there is no closure of eye, we can see the eyeball going up. So that is Bell's phenomena, right? Then we have the deviation of the mouth on the opposite side because there is intact elevated anguli oris muscle on the normal side which actually pulls it to the normal side, right? Then if the eye is not closing, there will be exposure keratitis. Exposure keratitis. For the lab investigations, we actually come across nothing. There is no actually diagnostic test as such, no specific test, but we see sometimes CSF have lymphocytes, lymphocytosis, increase in lymphocytes. In MRI, we can see there is swelling of the nerve, and sometimes the enhancement of geniculate ganglion, the ganglion of the facial nerve, right? Geniculate ganglion that is actually placed near the middle ear. Okay, so second, what are the tests you will do? We will say that kindly smile, kindly frown, right? Show your teeth, right? And that's it. Okay, so one more, close your eyes. So these are some of the things that you can actually notice. Now, last thing is the sequelae of Bell's palsy. That what happens when the Bell's palsy is not recovered fully, or what can happen? What are the complications? Number one is incomplete recovery. The recovery of the nerve is not complete. There is some, residual there is some residual weakness of the nerve. Then we have the exposure keratitis that was actually occurring in the eye, right? Exposure keratitis. Then we have synkinesis. Synkinesis is the mass movement. Mass movement means that when somebody wishes to close their eyes, when a patient is willing to close their eye, the eye doesn't close properly, but yes, there is winking of the mouth. So mouth twitches, right? So when the patient wishes to close the eye, the corner of the mouth twitches. So this is known as synkinesis. Synkinesis is this term, and opposite of this is the Marcus gun jaw winking phenomena. I'm discussing these two one by one because these are the two in which you can get actually confused. So Marcus jaw winking phenomena is whenever you chew, whenever you open the jaw to eat something, right? There is closure of the eye. So whenever you chew, there is closure of the eye. This is known as Marcus gun jaw. Marcus gun jaw winking phenomena. Winking phenomena. Then we can have the contracture of the muscle, contractures and fibrosis of the muscle. Then we can have the crocodile ears, or we can say the gustatory lacrimation. That is whenever you chew, whenever you masticate, there is faulty regeneration of the parasympathetic fibers which actually now supply to the lacrimal gland. So whenever we chew, the fibers which should come to the salivary gland, actually there is some kind of faulty regeneration that regenerates and supply to lacrimal gland. So whenever we masticate, there is lacrimation. So this is crocodile tears. And last is Frey syndrome, very very important. These two are very important. Actually, these three are very important. Frey syndrome, that is gustatory sweating. So this is also faulty regeneration. So basically, whenever you masticate, the fibers go to the fibers that should supply the parotid gland actually supply those glands in the skin of the person and leads to the sweating. So this is it. So for the treatment, for eye, we will give the drops. We will patch the eye at night. At night, we will patch the eye. We can use the paper tapes. We can use the lubricants, eye drops, right? And steroid you can actually prescribe yourself. Like, you should be patient enough that you should know the dose of this: 1 mg per kg per day for 1 week, and then for the next week you can actually taper up the dose, like half, and then it's half. Like, you can taper the dose. Antivirals are there, but we generally don't use them.